Hymenoptera envenomation includes stings from bees, wasps, hornets, and fire ants, which can produce reactions ranging from mild local inflammation to fatal anaphylaxis. Vespidae such as wasps and hornets can sting multiple times, while Apidae like honeybees leave behind a barbed stinger that rapidly injects venom. Fire ants grasp the skin and produce multiple circular stings with characteristic sterile pustules. The timing of symptom onset is an important diagnostic clue. Anaphylaxis usually occurs within minutes, often within 5 minutes, whereas large local reactions peak over 24 to 48 hours, and serum sickness appears after 7 to 10 days. Simple local reactions are self-limiting and present with mild pain, redness, and swelling, usually requiring only cold compresses. Large local reactions are exaggerated IgE-mediated responses causing swelling larger than 10 centimeters with intense itching, but they usually remain localized. A key clinical challenge is differentiating allergic inflammation from cellulitis. Large local allergic reactions are itch-dominant and peak within 24 to 48 hours without fever, whereas cellulitis presents with worsening pain, delayed progression, and systemic signs such as fever. Antibiotics are generally not indicated for uncomplicated sting reactions. Management of large local reactions is symptom-based. Pain-dominant reactions respond to limb elevation, cold compresses, and NSAIDs, while itch-dominant reactions are treated with antihistamines or topical steroids. Most patients with large local reactions do not progress to severe anaphylaxis, although a small percentage may later develop systemic reactions. Current guidelines do not routinely recommend epinephrine autoinjectors or venom immunotherapy for isolated large local reactions alone. Venom allergy remains an under-recognized cause of fatal anaphylaxis, with many severe reactions occurring in individuals without prior allergy history. Adults more commonly develop respiratory and cardiovascular compromise, while children often present predominantly with skin manifestations. Importantly, absence of skin signs in adults may indicate a more severe reaction. Venom-induced anaphylaxis is a multi-system emergency involving airway edema, bronchospasm, hypotension, shock, urticaria, angioedema, abdominal pain, nausea, and vomiting. Diagnosis is highly likely when rapid skin or mucosal symptoms occur with respiratory compromise or hypotension, or when 2 or more organ systems are involved after a sting. Serum tryptase can support the diagnosis of anaphylaxis if measured within 4 hours of the reaction, although normal levels do not exclude the diagnosis. The cornerstone of treatment is immediate intramuscular epinephrine administered into the anterolateral thigh. Some severe venom reactions may be refractory and require repeated doses and intensive care support. Discharge planning should include prescribing at least 2 epinephrine autoinjectors, patient education regarding future sting risk, and referral to an allergist or immunologist. Venom immunotherapy, or VIT, is the definitive long-term treatment for systemic venom allergy and reduces the risk of recurrent severe reactions from nearly 30 to 60% to less than 5%. Finally, toxic mass envenomation must be differentiated from allergic anaphylaxis. Massive swarm attacks cause direct venom toxicity rather than IgE-mediated allergy, leading to complications such as rhabdomyolysis, hemolysis, renal failure, convulsions, and shock, requiring aggressive supportive care and monitoring.